Welcome again, guys. Welcome. Thank you for another video. Let's talk about chest pain today. What do you do as an NP if you are meeting a patient coming with chest pain to the emergency room? Well, first of all, let's get in contact with the cardiologist, right? Let's get cardio on board. So basically, once they call you for report, for a patient that's coming in with chest pain to the emergency room, likely the emergency room doctor gave that patient nitro, likely aspirin, 325 milligrams, not the regular baby aspirin. Most likely they did an EKG. Most likely they did some troponins, some cardiac profile in blood. That patient might or might not have the cardiac enzymes elevated. So once you get to your patient in the emergency room, just get a little bit of history. Of course, any stressors. Sometimes when we have anxiety and maybe some issues at home, they might get these chest pains, unstable angina, we also call it. So get a little bit of history. Like I said, rule out any anxiety disorders. If we have any other history of hypertension, cholesterol, any heart-related issues, history of bypass cabbage, CAD, any AFib, if the patient is taking any anticoagulation, any Xarelto, any Eliquis, which is pretty much more the new ones, anticoagulation at home or by mouth. Get a little bit of history. Like I said, get in contact with the cardiology team. Some of the cardiologists, if they're not in-house, you can order some tests, which is pretty much the basic ones. You don't need a cardiology to tell you that. You can do a 2D echo. You can repeat the cardiac profile, troponins. I like to order another set, like every 6 hours times 2. If we have any history of AFib, or if the patient is doing some AFib on the monitor, you can start the patient right away on a full dose anticoagulation regimen. Heparin drip, Lovenox, the full dose, 1 ml per kilogram, BID. If the patient was coming in already on Xarelto, on Plavix, on Eliquis, you can stop those for now in case they're gonna do any cardiac cath in the morning. I like to keep the patient NPO for the night. Start the patient on heparin drip or the Lovenox, 1 ml per kilogram, BID twice a day, just in case the cardiology team is gonna do some sort of cardiac cath in the morning, especially if we had a history already of any cardiac related issues, or that's pretty much what you can do. Like I said, we can order the 2D echo, rule out any pericarditis, maybe even endocarditis who might show in the 2D echo. You can also see if there is any ejection fracture deficiency, Maybe there's some preserved ejection fracture going on as well, especially if you notice any swelling, especially in the lower extremities, any short of breath, also associated with the chest pain. You can also, of course, check the chest X-ray. It's gonna tell you a little bit if there is any volume overload or any pulmonary congestion. You can, of course, do the Pro BNP. It's a specific lab, Pro BNP. Likely, if it's elevated, then we are also dealing with the CHF, CHF diagnosis. So chest pain likely is not only gonna be a chest pain. Likely the patient is gonna have some other issues. But do your labs, do your tests, do the 2D echo, do the cardiac profile, do the anticoagulation, and get in contact with the cardiology team. That will be the first to do. Of course, do a natural PRN, just in case. You can do some morphine or dilated PRNs for pain as well, and keep your patient NPO, even though in case your cardiology team is gonna do any cardiac cath. So that's pretty much what I like to do first, without even thinking, when you have a chest pain diagnosis right coming out of your emergency room. Thank you, guys.